First of all, let me thank everybody for taking your time out to be here. So on behalf of Endometriosis Society of India, Apollo Medical Institute, Apollo Hospitals, as well as the ISOPARB Hyderabad chapter, we invite all of you for this afternoon to have a small session, I must say, on discussion about endometriosis. So I welcome our three guests from Kolkata, Dr. Arnab Basak, Dr. SUPARNA and Dr. Parthavatash. I have taken their time off and effort to come all the way from Kolkata to represent Endometriosis Society of India. The local Hyderabad ISOPARB President, Dr. Madhumati, thank you for being here. Dr. Krishna Kumari, HOD of Gynae Department, Apollo Hospital and Institute of Medical Sciences. So I welcome the delegates, the faculty, everyone, and let the games begin. Thank you.
I would now like to invite the chairpersons of the first session, Dr. BANERJEE. She's a senior consultant obstetrician, gynecologist, laparoscopic and robotic surgeon, and specialist in high-risk pregnancy and infertility. I would like to invite Dr. Krishna Kumari. She is a professor, Apollo IMSR, Hyderabad, senior consultant at Medicover Hospital, Hyderabad, and a vice president of Telangana Congress of Obstetricians and Gynecologists.
Okay.
Good afternoon, everybody. Good afternoon, everybody, seniors, friends, and juniors. We have Dr. SUPARNA BANERJEE from Kolkata, as Dr. ROOMA just mentioned. She's going to tell us about why we should offer IVF to our endometriosis patients. Now we have a big biodata here. Madam is the medical director of Ankur Fertility Clinic, Kolkata, and Institute of Reproductive Solution, Hooghly. Consultant gynecologist and infertility specialist at present. She's affiliated as the clinical secretary of ISAR Bengal 2022-2023, the secretary of the scientific committee of Yuva ISAR, executive member of the Subfertility and Reproductive Endocrinology Committee of BOGS 2019-2020, secretary of Bulletin and Website Subcommittee of BOGS 21-22, secretary of Subfertility and Reproductive Endocrinology Committee of BOGS 22-23, Assistant Secretary of Scientific Committee of AICOG 2023. Her major achievements: she's a gold medalist in her MBBS, DGO, MD, MRCOG. She's an orator in national and international conferences, and she's an author in many international journals and books. Dr. SUPARNA BANERJEE.
Am I audible? Yes. Good afternoon, everybody, and thank you, madam, for your kind introduction. I'd like to thank the Endocrine Society of India and ISOPARB Hyderabad chapter for inviting me, and special thanks to Dr. ROOMA for inviting me and giving me the opportunity to present before you. So the topic is endometriosis and infertility, basically. So the endometriosis prevalence varies depending on which group of patient you are treating. Its prevalence has been reported 5 to 10% in women of reproductive age, but for infertility patient it is quite high, 20 to 30%.
We are not able to slides. Connection is gone. The connection is lost.
Slideshow? Is it possible?
Go down.
Okay, sorry for the interruption, but okay. So infertility population, if we think it is 20 to 30%, so quite high prevalence. 40 to 60% women with chronic pelvic pain also suffers from endometriosis. Now, the biological mechanism that might link endometriosis to infertility is distorted pelvic anatomy, altered peritoneal function, altered hormonal and cell-mediated function, endocrine and ovulatory abnormalities, impaired implantation, oocyte and embryo qualities, poor sometimes, and abnormal uterotubal transport. Now, the inflammatory reaction, what it causes during endometriosis, increased number of immune cell, elevated cytokines, chemokines that can cause damage, reactive oxygen species increased, tissue fibrosis is there, and the mechanical damage is compression and stretching of the ovarian tissue that hampered blood circulation and disturbed neovascularization. Now, for a definitive diagnosis, as we all know that laparoscopy is a gold standard investigation for endometriosis, but sometimes patients present late because they think it is normal menstrual pain, and sometimes because diagnosis was at first not done due to either they did not do any imaging or it was not proper imaging or not examination, especially in pubertal girl. It is difficult parvaginal examination, so some painkiller was given, and there is a diagnostic delay around at least 7 years. SUA 2022 guideline recommends that clinical examination should be first to look for any nodule, and USG or MRI, depending on the facility you are working and affordability of the patient, for diagnosis is important. So one cannot jump just first for a laparoscopy, diagnostic or therapeutic. We need to know what we are dealing and where exactly is the problem. Now, positive histology during if we are doing a laparoscopy and taking a biopsy sample, so positive histology confirms endometriosis, but negative histology does not exclude. So whether the histology should be obtained, if the peritoneal disease alone is present, then that is controversial. But if there is a cyst like grade 3 endometriosis, then of course we take the cyst wall for biopsy. In case of endometrioma, which is large and deep infiltrating endometriotic disease, then histology should be obtained to identify the endometriosis and to exclude the rare instance of malignancy. Now the infertility, the fertility index with endometriosis, that is the scoring system called EFI, is a simple, robust and validated clinical tool that predicts the pregnancy rate and after endometriosis surgical staging. So its use provides reassurance to the patient with good prognosis and avoid wasting of time for those who have a poor prognosis. So this is the chart of EFI. So the surgical scoring, that was the previous one, we know left, right, tube and the ovary, that we need to see where exactly the disease is. And the new thing which they added is from the history point of view. If the patient's age is less than 35, she gets a good score of 2. If she is 35 to 39, then 1. And if she is 40 or more, then the score is 0. And the fertility history also very important. If the infertility is short infertility, less than 3 years, then a good score, again 2. If it is a more long-term infertility, then 0 score. And again, if there is a history of previous pregnancy, so if it is a secondary fertility, then it's a good score. Of course, we know that. And if it is primary, then it is again 0. So calculating both this surgical score and this historical part, and then we do this EFI. The score is more, then the good prognosis. The score is poor, then it is poor prognosis. So if the score is, EFI score is 9 to 10, that is good prognosis. So if they wait or do some mild treatment, probably chance of pregnancy in next 36 weeks will be good. Now regarding the treatment, now we have divided the treatment, medical, surgical, and then the assisted reproduction. Now medical treatment, of course, the patient who are trying for pregnancy, this is not ideal because it's not going to improve her fertility. But when they, after the operation, they want to postpone, like young patient, they want to postpone their pregnancy, then probably the medical treatment applicable for them. Regarding other medical treatment of ovulation induction, in that case, clomiphene for ovulation induction, like other patient, this group of patient also we can use clomiphene or letrozole or gonadotropin, depending on what is our AMH, age, and what treatment we are doing. Now the efficacy of ovarian stimulation isolated from other procedures, so only ovarian stimulation is not recommended for this group of patients. So if somebody is coming after their surgery, that is the best opportunity at that time for pregnancy. So we should utilize the next few months to make her pregnant. So do not do only ovulation stimulation and timed intercourse. At least better it is to be done with IUI. Now for mild endometriosis, minimal mild endometriosis is grade 1, grade 2. So objective of the surgery, of course not the only diagnosis, so we'll destroy and remove all the endometriotic implants, as data says that that improves fertility, pregnancy rate and live birth rate as well. Now ASHRA 2022 guidelines recommends that we should not do routine laparoscopy solely to improve fertility outcome. So as an infertility specialist, when a patient is coming for infertility only, so from sometimes with a good transvaginal ultrasound, we think she is suffering from infertility, though there is no cyst formation, but sometimes we see the ovaries are adherent, adenomyoma is developing, and of course her history may be painful menstruation or dyspareunia, then we can think of she is suffering from endometriosis. In that case, the need of the patient is very important. If she is suffering not that much of pain, then we should not just do for the sole purpose of improving fertility, do a laparoscopy, but definitely if she is suffering from pain, we need to treat her, and then probably laparoscopy is worth doing a laparoscopy. Otherwise, she can directly go for fertility treatment. Now for surgery for minimal endometriosis, so there is, of course, whenever we are doing a surgery, and in India we know, this is endometriosis surgery is quite complex surgery. Not all the gynecologists are trained to do that, but I'm sure we get patients that somebody else already have done the surgery and it is an incomplete procedure. Now, of course, surgery has got its own risk as well. So, need to think who is going to do, where they are going to do the endometriotic surgery, because we know that first surgery should be the best surgery. So one may question whether 30% of cumulative probability of being pregnant during 36 weeks justifies surgical treatment when one single IVF attempt is more than that, that is at least 40 to 50% success rate. Now for moderate and severe endometriosis, goal of the surgery is to restore normal anatomy of the pelvis and remove large endometriomas. No randomized control trial because of the ethical reason. Meta-analysis and observational studies suggest that laparoscopic surgery was superior than medical treatment. Now for medical treatment before surgery, that is not recommended. There is no evidence that it causes benefit or decrease the size or make the operation easier. So there is no evidence to give any such medical treatment before operation. If somebody needs operation, go for the operation. And GnRH, agonist, dynogest, these are all going to suppress the ovaries, and that patient cannot have fertility treatment. So we can only give after surgery if they are not planning immediately for pregnancy for their own personal reason. So after surgery also, it's not that somebody thinks that okay, we have not taken all the implants, we'll give medical treatment to suppress that. So that is not recommended. Now, management of endometrioma, the size is important, and if it is a small endometrioma, basically, if you do not do cystectomy, then evidence says that is fine, at least aspiration, and check the wall should be evaporated. But for a large cyst, of course, cystectomy is ideal. Of course, whenever we are doing cystectomy, then there is some loss of antral follicle will be there. So her assessment of before the operation for fertility assessment should be there, and of course after the operation also it needs to be done. But if we do not do the cystectomy, so chance of rebirth, for especially for the large one, chance of recurrence is very high. Endometriomas are present in 20 to 40% women with endometriosis. It is difficult to truly assess the effect of endometrioma per se on IVF outcomes, since most of the patients of these lesions also have other problem like DIE that can be an independent, that can have an independent effect on fertility as well. The effect of the size of endometrioma per se has also not been evaluated as an independent variable. So if somebody already had operation before, so for this presence of endometrioma, we do not jump on doing another operation depending on patient's symptom and the accessibility of the other follicles. And if it is possible, then probably they do not need another operation, they can have IVF. Now there are some reports says that laparoscopic excision of deep infiltrating endometriosis that improves IVF outcome. Operative surgery of DIE is not without major or minor complication, and all of us are not trained to do such a complicated surgery. So if it is, we are thinking of DIE or some MRI suggested that findings, then probably it should be done in a tertiary center, and the specialist surgeon who are dealing with this DIE and endometriosis. Now these are some old guidelines regarding surgery. ESHRE and ASRM both supported surgery if minor endometriosis grade 1, grade 2, if you are doing laparoscopy for some reason, then of course do the good job, that is take out the endometriotic implant. If it is grade 3, grade 4, cystectomy as I have mentioned, but pre of medical therapy and prior to IVF surgery must be done. This is not the case. Now, who are against the surgery, they can say that quality of oocyte retrieved in IVF cycle is not improved after surgery, and patients going for the surgery might extend their time for pregnancy, as after surgery they might take that, okay, I have a surgery, major operation, I will take few months rest and then I will do a IVF treatment. In that case, they might lose some of the antral follicles. And for the surgery, that the proponent of surgery will say that it helps in getting more oocyte for ART, and the outcome of the ART were not affected by the interval between surgery and ART. Avoidance of pelvic abscess and rupture of endometrioma is done by the surgery. Now, after laparoscopic surgery, what next? There are not many studies, but it's quite old study that suggests that there seems to be a negative correlation between the stage of endometriosis and spontaneous pregnancy. But after surgical removal of endometriosis, there is a statistical significance only reached in one study. That's why it's, but still issue recommendation if there is grade 3, grade 4, depending on the patient's previous history and the symptom, we should decide about the surgery. Now regarding IUI, if we see that sometimes we know that unexplained infertility, whom we call that we do not have the reason why their tubes are open, sperm is good and their antral follicle apparently good, so why still they are not pregnant? Sometimes they are suffering from endometriosis. So there are studies suggest that minimal mild endometriosis associated with infertility achieve lower success rate with stimulation and IUI compared to unexplained infertility, but unexplained infertility is sometimes due to endometriosis which we could not have diagnosed before. Now shortly after ablation of minimal mild endometriosis, clinical pregnancy rate improves, so or it's kind of quite similar to unexplained infertility. So it is conflicting data available. Now IUI is typically not offered for women with severe endometriosis. As we know, their pelvic anatomy is distorted and there is adhesions, so we should not offer them IUI. ASHRA 2022 guideline recommends IUI with hormonal stimulation, that is gonadotropin, for stage 1 or 2 endometriosis rather than expected management or only like clomiphenol letrozole stimulation and timed intercourse. In infertile women with stage 1 to endometriosis undergoing laparoscopy prior to the treatment with ART, clinician may consider complete surgical removal of endometriosis to improve live birth rate. Now for IVF, so live birth rate for endometriosis group, IVF live birth rate was found to be similar for like minimal mild endometriosis like any other cause like tubal factor. But for moderate and severe endometriosis, live birth rate is low because of we get fewer oocytes and lower implantation rate and low birth rate. Now for IVF, how shall we stimulate? So ultra long protocol, now it is not done anymore. So there was for this group of infertility patient, post-operative also, we used to give a long suppression with GnRH agonist. Nowadays it is not recommended. But regarding agonist protocol or antagonist protocol, it is up to the clinician what she is comfortable with. There is everything has got its pros and cons. But agonist protocol sometimes, which is I think long-standing protocol in our country, in the world, and some of the consultants still prefer agonist protocol. Though I use mostly antagonist protocol, but agonist has got its the good thing about it is yeah, you can suppress the her ovarian her LH FSH activity. The down regulation starts from the cycle before, that is mid-cycle of the previous one where we are going to start IVF. So definitely its suppression is more, but then you need to use more gonadotropin to stimulate that ovary. You might get 1 or 2 egg extra, but regarding the live birth rate, that is kind of same for agonist and antagonist. There is no difference. For antagonist protocol, it is good choice for poor responders, and especially these grade 3, grade 4 endometriosis patients. They are sometimes poor responder because they have got low AMH and low AFC. So antagonist cycle is also good for them. Of course, it prevents the LH surge if we apply the LH in right time, the antagonist in right time. Now, for clinician can prescribe GnRH agonist for a period of 3 months prior to treatment of ART, especially if we are dealing with the FET. So if suppose we have already done a IVF cycle and her embryos are there in our center, then we can do this suppression, because they did either we did the operation after the procedure, or they have their own plan. So we are in between, they have some time, so we do not want their normal menstrual cycle to start again, because they will have again painful period. We can suppress this group of patient, and we see the success rate for this group for FET is good. Now for surgical treatment prior to IVF, a systematic review published in Human Reproduction in 2015, it suggests that surgically treated endometriomas compared to those with the intact endometriomas and both having IVF. So similar live birth rate, clinical pregnancy rate and miscarriage rate. But of course who had operation, they have lower antral follicle count, and they required higher doses of gonadotropin for ovarian stimulation. Now women who undergone surgical treatment for unilateral endometrioma, they have lower number of oocyte retrieved from that ovary, but that is compensated by the contralateral ovary, sometimes we see that. And the potential physiological compensation of the normal ovary in those cases. Now regarding ART and agonist, long-term pituitary downregulation frozen embryo transfer, those are studies, retrospective studies suggest that if we are downregulate them and then do the HRT cycle, that improves the success rate. Now GTG recommends that the clinician counsel the patient before the endometrioma surgery, because we need to counsel regarding their ovarian function, what exists, and there will be some loss of ovarian tissue, her AMH will be low, and she will lose some of her follicles. That also needs to be counseled before we embark on any surgery. The effectiveness of surgical excision of deep nodular lesion before the treatment with ART in women with endometriosis also need to be established. So whenever we have done any investigation, we have seen the chocolate cyst, the endometrioma we know, but if we see after going inside the tummy and we see the DIE is there, we should complete the job so that she should not have another operation for her pain again. Now risk of ovarian cancer, yes, it is there, not very high, but there are risk of endometrial cancer like ovarian cancer, like clear cell cancer or endometrioid histology. So that's why it's recommended that if we do the operation, do it completely and send the sample for histology. So though the probability is very low, clinicians should counsel their patient for this cancer risk as well. Complication during surgery, although the results of epidemiological studies are contradictory, some evidence suggests that association between endometriosis and miscarriage, placenta previa, preterm delivery and IUGR all are very high in this risk, in this group of patients. That might be due to their fertility history, their age, so it is per se for endometriosis it is very difficult to say, but yes, they suggest that outcome of pregnancy sometimes is not as smooth as other pregnancies for any same age group woman. Now risk of disease progression during IVF cycle, endometriosis is an estrogen dependent disease, so there always a theoretical risk that when we are stimulating her ovary, that her chance of again recurrence of the problem would be there, but there are no evidence that suggests that if we do, no matter it is IUI or IVF, if we are stimulating her ovary with gonadotropin, that will increase her chance of recurrence. But one group, they have done a study where they have done, they stimulated the ovary with letrozole, like in a oncology patient, during stimulation we use letrozole to minimize the level of estrogen. And but there are no big studies to suggest this will improve her, this will prevent her recurrence, and if we do with gonadotropin, that will increase her recurrence. There is no evidence. Now, in an iatrogenic injury, if we are when we are doing in IVF pickup, ovum pickup, and if there is already chocolate cyst present, So chance of iatrogenic injury after oocyte retrieval or inadvertent puncture of the endometrioma, that is also minimal because it is after all ultrasound guided procedure, and whoever is doing, they are quite expert, they should be quite expert, they should not inadvertently puncture an endometrioma, but if it is punctured, of course antibiotic prophylaxis we always use, so chance of pelvic abscess is very rare. Though the study says that it's quite rare chance, but these things are very underreported, so actual incidence is very difficult for us to tell. Now, RCOG 2017, they have suggested that technical difficulties during oocyte retrieval is very low if there is an endometrioma, and no data suggests that surgery will prevent adhesion formation and facilitate oocyte retrieval. So, and risk of infection of endometrioma is quite low, 1.9%, and follicular fluid contamination chance is also very low. So, because she has an endometrioma, do not do a surgery or laparoscopic surgery if she is asymptomatic or already she had gone through operation before. Now, adenomyosis, this is another condition very much associated with endometriosis, and it is, I will say, as a fertility specialist, late 30s and in sometimes early 30s also we see most of the uterus, they are adenomyotic. No matter patient is symptomatic or not, adenomyosis is so common. Sometimes we think probably we are wrong, seeing all the patient and diagnosis, all the patient heterogeneous and myometrium. So it's that common. So condition in which the endometrial tissue exists within the muscle tissue, there can be a global adenomyosis or focal adenomyosis. Again, operation will depend if you are going for surgery or not, depending on the situation, individual patient. Some are totally asymptomatic and uterus is not that big, like global adenomyosis, then you cannot cut a particular place to improve your outcome. But if it is a focal and like a nodule, probably as patient is symptomatic, then surgery can be done. But if it is a global, the problem is that the endometrial cavity length is very important for our transfer, as our catheter has got a fixed length. So if the uterus is very big, more than 10 centimeter, it is very difficult to put the embryo in a right place near fundus. So then we want this size of the uterus to be reduced. Either it can be surgery or medicine for long-term use like GnRH analog for long-term use, so that we can shrink the size. And nowadays Dynogest is also doing the fantastic job to reduce the size so that we can place the catheter and put the embryo in a right place. Now, of course, medical treatment in this group is very important because of this. It is a hormone-dependent condition, and if we stop that hormone from pituitary, then probably we will achieve it. Of course, it improves the inflammatory reaction as well. Now, case series with GnRH agonist, it shows that it is effective in improving pregnancies in women with endometriosis, and most of the data are observational. Now, this algorithm, as I have already mentioned in my talk, but if somebody is presenting with infertility, then first infertility workup. If they, depending on the EFI score, if they have already surgery, if it is not a surgery case, it's presenting only with infertility, at least ultrasound or MRI if it is, you think so, or transvaginal ultrasound, 3D ultrasound are very good nowadays. So we assess the thing, and then we decide, depending on the patient's age, her fertility wishes and the conditions she is presenting with. Directly they can go for IVF, especially the older group, and if they are younger, they have time, not endometriotic cyst is not there, only mild minimal endometriosis, surgical treatment for pain, and then IUI, and then if it is not successful, go for IVF, or if it is moderate severe endometriosis, depending on after the surgery, how is her recovery, they can be pregnant with IUI or IVF. Now, in summary, there are few published randomized trials for management of endometriosis. Before planning a fertility management in endometriosis, patient's age, duration of infertility, other combined cause of infertility like male factor or tubal factor should be assessed, and ovarian reserve, her pain symptom and the staging of the endometriosis should be evaluated before offering her any fertility treatment. Sufficient information about the patient's condition and management option should be provided beforehand, and laparoscopy can be done to restore normal pelvic anatomy as completely safely possible. Surgery might improve fertility, but repeated ovarian surgery should be avoided. If natural conception does not occur within a year after surgery, then clinician should consider ART. Now for stage 1, stage 2, of course ovarian stimulation with IUI we can try, but if patient's age is more than 35, then probably they are candidate for IVF. Or stage 3, stage 4 endometriosis, their surgical treatment, after the surgical treatment, they can directly go for IVF. Clinicians are advised to assess ovarian reserve prior to deciding operation, surgically remove the endometriosis, and after at least 3 months after the operation, you will see that decline in AMH, and then you decide how much time you have to wait for natural try or IUI or IVF. Individualized care provided with this in mind to women with endometriosis prior to IVF may help to optimize their pregnancy. Thank you very much.
Thank you, Dr. SUPARNA, for your really elaborate talk on fertility in endometriosis. I think most of us here are general obstetricians and gynecologists, not IVF or fertility specialists. Maybe hardly one or two, or a few of us are fertility specialists. Are there any questions from the audience? Yeah. ROOMA? Madam.
Oh, sorry. I don't know. Yeah, okay.
Yeah, good afternoon. So in my 4 decades of journey in the practice, I have seen so many practices changing, so many guidelines changing. And long ago for endometrioma, we have been decades ago. We were aspirating ultrasound guided aspiration and then injecting ordinary rubbing alcohol. And we found very good results. But then there were several papers saying that this is not a good practice. It may produce infection, leakage, and so and so. So we stopped doing it. Now again with the recently revised tertiary guidelines 2022, the emphasis seems to be more on non-surgical and medical treatments. And again there have been several papers, aspiration of endometriomas up to even 5 centimeters in diameter to avoid surgery. Flush it out. You have mentioned about laparoscopic drainage and then flushing, and so the same thing, ultrasound guided aspiration of the cyst and flush it out with normal saline, and then inject the escalon, whatever that refined alcohol. So there have been several studies. Do you have any, you or Durga also is here? So do you guys have any experience on this particular thing, or?
I think we are talking about vaginal aspiration.
Aspiration ultrasound guided, yes.
And sclerosing therapy. What madam says is both aspiration with sclerosing.
I found several papers again with rekindled interest in these things.
But madam, we always have to be a bit cautious regarding that, because there is a small inadvertent complication in terms of ovarian abscess. So as much as possible.
But the same thing can happen when you are aspirating the eggs also, right?
That depends on whether you can avoid the The point is avoid the endometrioma if possible. But if the follicles are not accessible, then it's preferable to do a laparoscopic cystectomy and then go for oocyte pickup. So the baseline scan is extremely important for us to understand that.
And
Whether
now,
the follicles are accessible or not.
okay. And also in stage 1 and 2, just to make a diagnosis, now the guidelines say that it's not required.
It's not required.
Diagnostic laparoscopy is not required. So when it is not required, the medical treatment and then proceed, because empirical medical treatment again is recommended. So can we just give
Empirical medical treatment for stage 1 and 2, madam?
Yes, empirical medical treatment.
No, for which? Pain relief or infertility?
Pain,
Not for
infertility. Pain, for
Yeah.
pain.
For pain relief, yes. That is recommended. That can be ocipil as well. NSAIDs, ocipil. But for infertility, we know that we need to do something, otherwise we are going to lose that patient because she might develop endometrioma in later stage. So we need to do either a IUI or something, not sit tight and do try yourself.
Laparoscopy? You mean?
So that I'm saying now, previously when first, as I am a student, that time also laparoscopy, diagnostic laparoscopy was in my hospital. I was tend to do laparoscopic diagnosis but not the therapeutic laparoscopic, any management. But that time also, the ultrasound machines were, I don't think, that good, and the transvaginal probe clarity was not that good. That's why diagnosis of endometriosis, mostly we used to say that is the gold standard. But nowadays, with our experience and with very good machine, we can diagnose endometriosis in a very early stage. Like sometimes, depending on who is doing the ultrasound, some transabdominal ultrasound might not be how the ovaries are adherent, how small chocolate cyst, which just some in abdominal scan they might ignore that, but you can see that is not a corpus luteum, that is a small chocolate cyst developing. Then we know that patient is for endometriosis. You can say she is stage 1, stage 2, or going to be stage 3 if we wait and do nothing. So we can start treatment for her.
We will have many of these discussions in the case-based discussion. So thank you.
I thank the speakers and chairpersons of the session. I request Dr. Madhumati to present a memento to Dr. SUPARNA Banerjee.
Give me 2 minutes. Suparna, please, on the stage.
I request Dr. Vidyadhari to present mementos to Dr. Priyambada Reddy and Dr. Krishna Kumar.
To the chairperson, please. Priyambada. Thank you, Dr. Suparna, for your very lucid talk, and a lot of things on infertility and endometriosis got discussed. Why I tried to curtail the discussion, because a lot of these discussions are going to come up in the case-based discussion that we are having, and we would like to continue this on time. Before we begin the next part of this meeting, I would first like to actually invite again all of you on behalf of Endometriosis Society of India. Now, all of you are aware this is a national body that works on both awareness as well as clinical teaching, as well as conducting CMEs and meetings for endometriosis. I would actually like to welcome Shanta. Thank you so much for joining us. I know your interest was to meet your friend, but really thank you to join us. I'd like you to come on stage with us. We also have an interesting update that we come every 3 months called Endometriosis Update. I'd like Shanta to actually kind of inaugurate this update for us for the first volume on 2023. Please join with me, Shanta. Dr. Shanta Kumari, for all of you, is the past president of FOXY and at present the treasurer of FIGO. And I'm sure we all wish and pray that she will next be the president of FIGO and bring India to really at the world map. So Shanta, please welcome. This is our endometriosis update. I will actually put it on. Okay. So you can just scroll down. Wow. So this is an update which we come out every 3 months. This update is mainly targeted for general gynecologists. We talk about certain issues in which you will find many of these being discussed today in the case-based discussions. And this particular issue has how endometriosis has obstetric complications, how do you manage an endometrioma, what are the newer theories in etiopathogenesis of endometriosis, which has been given by one of my colleagues from St. George's Hospital, London. Dr. Meenakshi from Chennai has talked about how to tackle an endometrioma, which is the commonest gynecologist operate as laparoscopy. I have also put up a video of doing how to do a radical hysterectomy in a grade 4 endometriosis. And we of course have our psychologists talking about how body and mind interactions can be done. Dr. Praveen has been kind enough to add a chapter on how to do and diagnose endometriosis on scan. So this will be circulated to all of you with WhatsApp. Please do read. They are very, very simply made and meant for every gynecologist. Thank you so much, Shanta, for launching this. And I'd like Shanta to give a few words.
Thank you, Rooma. Good afternoon, everyone. Greetings from Foxy and Figo. Yeah, it's a pleasure to be here. Let me be honest, I came to say hi to Arnab, okay? He's my classmate. Okay, it's a pleasure to see, and nothing like friends. And when I come here, I see all the who is who, Savita Madam, Vidyadhari Madam, Manju, Krishna and all, and it's so many others. Rooma, very good. I think this update, writing books, everything is very, very good, but off the record, let me tell you, I'm very disappointed because the people who are writing, there are hardly anybody reading. This is my observation in Foxy, national and international, I'm saying. So what I think what is needed is now we need to inculcate the habit of reading also in the little, in the next level, because we want them to take care of us. No, I and Manju always think we need to train the juniors because they are the ones who are going to take care of our health. So I think that is very important. And so it's not so easy to come up with an article or an update or a book. It's so very difficult. So the amount of work which goes into any written material, I think the best output would be only when there are people who are going to read it and get updated and make the best use of it. So I hope and let's see that people will read it. All the best for this and really a happy moment to be here. Thank you all. Bye. I think let me take a minute more. On the 9th of April, we have the Obstetrician Society of Hyderabad, the Yukti program. So look forward to seeing many of you there.
Thank you, Shanta. I think that observation is very correct. But so we have made this update very, very phone friendly. It's in a PDF format given to you in WhatsApp. So you can read it in between seeing two patients as well. I would now like to request Dr. Partha Bhattacharya, who is now the General Secretary for Endometriosis Society of India and has come all the way from Kolkata, to give a token of appreciation to Dr. Shanta for being here with us today. Thank you, Dr. Partha, and thank you, Dr. Shanta.
Now we move on to our next session, which are case-based discussions. I now invite the panelists for the next session. Dr. Y. Savita Devi, she is the Director Endoscopy Training Center, Senior Consultant Obstetrician Gynecologist at SUPARNA Healthcare and Well Women, Hyderabad. I invite Dr. Manjula Anagani, Clinical Director and Head of the Department, Care Hospitals, Hyderabad, Visiting Laparoscopic Surgeon, NMC Hospitals, Dubai, Honorary Associate Professor, India University of Health Sciences, and a Founding Secretary of IAG, Telangana Chapter. Dr. Krishna Kumari, Professor, Apollo IMSR, Hyderabad, and a Senior Consultant at Medicover Hospitals, Hyderabad. Dr. T.L.N. Praveen, Professor of Radiology and Director at Abhishek's Institute of Imageology. Dr. Durga Rao, Co-founder and Medical Director, Oasis Center for Reproductive Medicine. I invite Dr. Arnab Basak, Senior Consultant Minimal Invasive Pelvic Surgeon, Apollo Multi-Speciality Hospitals, Kolkata. I invite Dr. Partha Bhattacharya, Obstetrician and Gynecological Specialist at Maniktala ESI Hospital, Kolkata. I would like to invite the moderator for the session, Dr. ROOMA SINHA. She is a gynecologist, minimal access and robotic surgeon, Apollo Health City, Jubilee Hills, Hyderabad.
Alright, welcome back again. If my panelists are settled, we'll start. Thank you. So, this is something where a lot of discussion happened when SUPARNA was giving her talk. But we will now take it as a case-based discussion, and especially it will be useful for the young budding gynecologists, laparoscopic surgeons, and our fellows are there in the hall to understand what our experts are going to talk and think about when a case is presented to them. So we already have this list. Let's start with the beginning. And beginning is understanding the disease. Why endometriosis is being talked about so much, why it is difficult to diagnose, why there is delay in diagnosis, why we are worried about managing these patients, why patients suffer so much, is all because we have still not understood what is the etiology. So to my panelists, I would ask my first question. What theory do you think is most relevant? We'll start with Dr. Arnab, right in the beginning.
Yeah, I think even today Samson's theory pulls some water. So theory of retrograde menstruation, and the other thing is the metaplastic theory. These two theories are probably the most relevant today. But then there's a lot of talk of epigenetics, and there's a lot of research being done on the genome project. And we have to wait for the results, too early days, and I'm happy to say that I'm also involved in one of the ICMR projects, which is doing a research on GWAS. Where we are trying to find out whether there are polymorphism. So that is another theory which is coming up. I think these are the 3 years old.
Dr. Krishna Kumari, do you think there is anything more new other than the Samsons that holds water today in trying to understand? Because retrograde menstruation is not an uncommon feature. Why one develops and why one doesn't?
So, keeping Samson's theory as a baseline, I believe strongly that it is the inflammatory changes that are happening secondary to that, which is very much personalized. Why one person reacts to that retrograde menstruation, like you rightly said, it is a very common thing. But why some people react to that retrograde menstruation is what we have to understand. I think with the trying to put inflammatory markers as a criteria for identifying the disease, probably we will come into a more better way of understanding the disease as well as treating the disease.
I think because once we understand, it will probably make a difference about how will it implicate our management strategies. Because for some patient, disease is very aggressive. For some, it remains indolent for time. Some do not develop. Some develop very fast. So we really have not understood. So this, and then plus decision regarding who will recur after my treatment. But that's very. Dr. Manjula wanted to add.
Totally agree with Samson and the metaplastic theory. Epigenetics and the cofactor, that is what is very important, because the rampant increase because of EDCs. We know that endometriosis is increasing because of some inciting factor there in a particular patient who has an epigenetics as a base. So I think we should be looking more into.
In fact, just 2 days back, I was in face-to-face discussion with Dr. Karman Nezat regarding his end of March, and they had a few doctors whom they invited, and I was fortunate to be one of them. I was in fact giving that talk to him from Tokyo airport as I was flying out. But the question he asked me was very relevant. He asked, does this matter? The pollution, the exposure to so much. So the endocrine disruptors are actually changing the epigenetics that we are talking about and making some of us more susceptible. And that is why we find disease in young women so much. We were not finding it 2 or 3 decades back. So that's what is actually the thing to be thought. And of course, research, like Dr. Arnav said, has to be progressed. And we have to keep working on it. So we can have a new unified theory. Consideration of epigenetics, macroscopic alterations in the environment. Idiopathy can be extremely complex. Interaction of various factors, like Dr. Manjula said. So it's very challenging to actually, you cannot produce an endometriosis in a monkey and try to say, okay, these factors are the only ones that are working. So it's very difficult. So discovery of these aberrant genes are what I think Dr. Basak is working on. So great.
Just
so,
one point, Ruma.
Yes, ma'am.
The EDCs, it can even affect the intrauterine fetus.
Yes.
If the mother takes all these benzophenols and
Yes.
these phthalates and all these things, the fetus also is because of epigenetic changes. So fetal origin of adult disease.
Yes.
That again we
Perfect. So we'll start with the first case. Now this is a 39-year-old para 0. She had multiple rounds of infertility treatment, ultimately adopted. She had 2 laparoscopies in the past, but when she came to us, the complaint was severe congestive dysmenorrhea, dyspareunia, which has been happening for last 10 years. Her cycles are regular, but heavy menstrual bleeding with clots. She is now in a state of total mess, anxiety, depression, on multiple medications. She obviously has bloating, constipation. Her acyclical rectal pain is what she is bothered with. Now she came to us after many years of visiting many gastroenterologists, and they labeled her as proctocalgia fulminans and gave her Dalcoflex suppositories. She is just managing herself. But when she came to us, we tried to understand and we asked her one question. Does all this problem exacerbate at the menstrual time? And that's the crux of the question. And I think Dr. Manjula is shaking her head, and I believe, maybe both of us believe, that it's time to counsel and make our GI especially, or the general physicians or the general practitioners sensitive to this fact that patients coming with chronic pelvic pain ask this question. And if this question says yes, ask them for a gynecological evaluation. And then in this clinical evaluation, how valuable it is today, maybe I'll ask Dr. Manjula to begin with, is your pelvic examination. Would you replace it with just a transvaginal examination?
No, for me, it's always the examination, not just the scans and not just what the symptomatology. It is the field which is very, very important.
Of course. Clinical examination is number one. Without doing that examination, we cannot even think of doing any investigation.
Absolutely. So in this particular patient, we did the clinical examination, and this is what I kind of put in my mind when I do a clinical examination of a patient where I'm suspecting endometriosis, right? So I need to see the cervix first. The cervix is tender, not tender, and many times if you have done enough of speculum examination, you'll find these cervices actually deviated towards the left. Often the left uterocycles are involved and the cervix is deviated to the left and tender with reduced mobility. Then you check the paracervical areas. Do you find any tenderness there? Then you look for the palpable, both levator and eyes, right and left. Are they tender? Is there having pain? And then finally, you will actually look into all the other factors. So in this patient, cervix looked healthy, uterus was bulky, fixed, posterior vaginal nodule can be felt, tender and severe, and uterocycle ligaments felt taut, especially more left on the right. And again, I think this question shall I ask one of the fellows. Why left endometriosis is more common than right? Anybody? Hands up. Okay. Yes. Sit down, you can sit and speak.
Sorry.
There is a theory
some movement of the molecular movements in the peritoneum, and that's why the left side is more common.
Yeah, so if you understand the physiology, the movement of the peritoneal fluid in your abdomen moves from right to left. That's the first factor. The second factor, you have a sigmoid there. So everything gets collected. And that is why the deposits are more on the left side, and you most often find that, I'm not saying you don't find it on the right side, but you find very commonly on the left side. And in this patient, when we did a PR as well, there was no bleeding, tenderness and the fixed nodule well said, and the rectal mucosa is something which we need to feel. Dr. Krishna Kumari, would you like to add anything more to the examination that we were talking about?
You've already done a PR?
Yes, the findings are there.
Okay. So I think we had an abdominal examination. We have a examination of the perspective examination, a bimanual examination, and a rectal examination. Yes. Now I think with this I would like to have with this idea I think I would like to move ahead with investigations.
We are coming there right now.
Yeah.
So this is just few for the residents. Red flags on examination, fixed retroverted uterus, adnexal mass, lesions in the cervix or posterior fornix, very often seen. And you can see I've made a diagram where cervix is pulled towards the left side of the vagina. Now, then we come, of course, the examination should follow the imaging, and then we will take help of Dr. Praveen. So this patient, ultrasound done regularly, was reported as uterus 9 into 7 into 6 centimeters with coarse texture, meaning there was adenomyosis. There's a posterior wall fibroid, there's a posterior wall fibroid, left ovary 4 into 5 centimeters, right 3 into 3, not really classified very well, and advised clinical correlation, which we find in ultrasound examinations so often. So what would you like to add here?
Yeah, thank you for giving me this opportunity. First and foremost thing is, when we try to compare digital examination with transvaginal examination or an endocavity application, I feel it is a complementary to the digital examination.
Yes.
The reason being that there are certain, what you call as soft markers which can be easily perceived, and they say the perception with the transducer, and there are certain instances where now they have a finger transducers. You put the transducer onto your finger and do a digital examination. That is the latest which is being used.
Do we have it?
No, I don't.
Anybody has it?
No.
Okay. It would be lovely.
Yeah.
And
Sure.
is it also, I heard, it's coming on to the phone also the same
Of
thing?
course, yeah, that can be connected to it.
Okay, Manju, when you have it, let me.
That's an out.
We'll buy together. That's it.
So that is one most important thing that I wanted to convey. The second most important thing is then when you evaluate pelvic viscera, particularly when it is focused on endometriosis, the most important thing I would like to have is a four-step approach. That is what is called as the IDEA, that is the International Deep Endometriosis Analysis Protocol. And not only that, the most important thing is that when you try to introduce your transducer, first and foremost thing is it has to be gentle. Second important thing is the normal anatomy has to be defined. For example, anteriorly you have the urethra, bladder, and then you have this vagina.
Slide.
Pointer.
Pointer? Do you have a pointer? Pointer head?
No, it's okay.
No pointer.
It's okay, I'll come.
Yeah. Sorry, I'll play it again.
No. Yeah. No, I can't see.
Yeah, this is a pointer.
Yeah.
I'll play again.
So when you start evaluating the pelvic viscera, transvaginal or endocavity, the most important thing is we need to identify the normal anatomy. So that is the bladder, that is the urethra, that is the vaginal canal, and that is the rectum. These are the three most important landmarks that one has to identify. Not only that, while introducing your transducer itself, you can see the anterior vaginal wall. If you are trying to focus on to the anterior fornix, the most important thing is to evaluate the anterior vaginal wall. See, this is the anterior vaginal wall. This is the bladder, and that's all the anterior vaginal wall. And then the cervix comes. So I try to, first and foremost thing, as you are gently introducing and in a graded fashion, you try to evaluate all this anatomy, then go to the cervix. From there you go into the uterus as well as the endometrial cavity, and then look for the adnexal region. This is the approach that we follow. Most important thing is, while we are doing these things, there are two things that you would like to elicit. One is what's called as the site-specific tenderness. That is, with your transducer, you try to push, and when you know that there is a wincing of the patient, then you know that it's tender. That is one. Second important thing is that whenever you have a fixity, what is called as the sliding sign. There is normally these pelvic viscera should slide one above the other. That is what is called as the positive sliding sign. And that means that it is normal. Whenever the sliding sign is negative, as you can see, is I'm trying to push, and then you can see that they are not moving one above the other. So when you have a negative sliding sign, it indicates that there is adherence. So these are the two soft markers that can be easily identified and made use of in evaluating. And not only that, this is a classical appearance of a fixed, retrofixed uterus, which is what is called as the question mark sign or a comma sign. So these are all the features that you are trying to evaluate. Associated with it, you will even evaluate the myometrial abnormalities, and then try to evaluate in a systematic fashion the anterior compartment, middle compartment, and the posterior compartment. This should be the approach.
I'll ask you a technical question here. This idea way of 4-step evaluation of the pelvis, I think most of us do, right? I think Dr. Durga will agree, Dr. Vasak will agree. Now there is a lot of talk about NZN classification and NZN way of doing even scan. What is your take on that?
Yeah. I would take it this way. I would like to use idea for diagnosis, and I would like to take NGN for grading.
Okay.
Because you have a specific classification or a code being assigned based on the involvement of various structures. Like you have the pot, that is the peritoneum, ovarian, and the adhesions. Similarly, involvement of, when you are not able to identify any of the pelvic viscera, you call it as X. So if FA is, all those things you know.
Okay.
So what I would like to do is, I would like to use the IDEA protocol in order to get the information that is available. Based on that IDEA protocol, the information that has been gathered by the ultrasound, then I make use of the NGR to grade the or code the lesions.
So this is the question.
That helps us in assessing the severity of the lesions.
Yeah. So this is a question to both Dr. Savita and Dr. Manjula. How often do you use this kind of grading, imaging wise, before you go in for surgery? Or do you think it is, or you are still blind?
Idea has been, we have been using it without knowing, giving a name to it.
Yes.
We have been doing it for decades now.
True.
That's the way we used to diagnose endometriosis.
Unfortunately, we don't publish, that's the problem. So somebody takes the name from us.
Absolutely.
Yes.
And then,
so the measures to the juniors, publish.
Like Dr. Praveen said, IDEA gives us the protocol, how to do it. And then NCN, it gives us the scoring, so that the studies can be compared and then we can know.
So do you do it in practical purpose? I want to ask Dr. Manjula.
See, most of the time I really believe seeing is believing. There is two reasons for it, not because I am like we were just discussing. Next generation who's doing the scan will not be Dr. TL and Praveen.
Absolutely.
So I'm not very clear that they, depending on that I should go. So I'll have an open mind. Yeah, even if they give the scoring, say, telling that our rectovaginal nodule is involved, or rectum is involved, and what is there, we make a scoring, agreed. But again, saying that unless I go and correlate, maybe I will not be trusting that particular radiologist for anything.
Okay, question to a comment from Dr. Vasak. I think whatever we do fly a little blind in endometriosis, right?
Yes.
How do you counsel your patients?
See,
what do you tell them?
Okay, before I get into that, just
Sure.
1 minute.
Take your time.
Wanted to see. Problem is even in our city we don't have Dr. Prabhu to do ultrasounds.
We are lucky.
You're very lucky, and believe me, I mean, last 10 years that's my project of trying to get our radiologists to get into the women's imaging and trying to figure out little bit of the soft markers and stuff. Still today there is a lot of diversity and a lot of
observer variation
in reporting. I mean, it's there. So when you're talking about #NZN, one, I do clinical NZN, I do ultrasound NZN, I do MRI NZN.
And laparoscopy.
So that's the next question.
Finally, laparoscopy.
Okay, yeah, okay. Anyway, we are flying little blind. We know, Dr. Manjula and I know that many times. We are told something and something else comes out. So the next, just the question, before we go any more, or we can come to that question a little bit later. Dr. Praveen, do you think, I know if somebody is not as skilled as you in telling us the information on ultrasound, do you think people like us can depend on MRI?
I'll tell you, MRI...
What is your take?
I'll tell you, MRI gives us the spatial resolution. When I say spatial resolution, particularly when we are bothered about the endomyometric junction, which is basically the junctional zone disease, if that is the one which we are focusing at, definitely the early pickup will be there in MRI. MRI is always a complementary to ultrasound, that's one.
True.
Second one is most important, these are soft markers like the tenderness and cannot be assessed.
Absolutely.
So, and then not only that, now today the present thinking is that you need to map the endometriosis. When I do an ultrasound, I need to map the endometriosis. That means when I map the endometriosis, I will tell you the location, I will tell you the severity, I will tell you the involvement of these structures. So that will help you in planning your surgical or whatever they think. Like having a colorectal surgeon with you or a urologist with you, all those things. So that is what is more important than comparing two imaging modalities which have their own pluses and minuses.
Of course. So, Dr. Vasak, you were speaking to me, we were talking something.
And MRI also man behind the machine, yeah.
Yes.
Okay. So, I will just have...
It's
it depends on the sonologist. If you have someone very good, then actually I rely more on my sonologist, Dr. Mejabin, rather than on MRI.
Absolutely.
Being given by somebody
Okay, one
else.
comment from Dr. Basar before we move. He was talking to me something in the lunchtime regarding using MRI, right? Okay, tell us your experience. Why you use it? What benefit you get?
Right. So, since there is an inter-observer variation in sonography, so we have not shifted, but it is a complementary, as you rightly said. We do a TVS, but then to get more information, we always do an MRI. In MRI, we have devised a protocol which is known as the endometriosis protocol. Previously, we used to do only contrast, then we said that contrast is no good, we don't need contrast unless you are actually thinking of something like diffusion restricted studies and all this. Otherwise, not T1, T2 weighted images are good enough. So now what we do is we put jelly in the vagina, we put jelly in the rectum. Only thing is you have to make sure that the jelly is air bubble free. And then the contrast is excellent. That gives us the DI lesions, the mapping. So how many are there? What is the extent? What is the size of the lesion? Whether it has, how much it has penetrated the muscularis. So these are minutiae information that we need.
I think that answer quite perfect, and I will just add one comment from me, is that when I am dealing with patients and many years over, I don't have the same sonologist all the time, like Dr. Savita has the benefit of. So when the sonologists change, their inter-observer does not tell me this. So for the last 10-12 years, I've started getting more dependent on an MRI. Not that I would say it is replacing my ultrasound, but what the MRI does is 2 or 3 things. One, now I can read my MRIs because I don't need a trained person for me to read. I can more or less understand. If I have a problem, I take the CD and read it with my radiologist. That's the first thing. Second, I can actually show topographically to my patients very well. See, this is the lesion, this is like that, they also get a picture. And I've found that very useful for my myomas as well. So I can tell them this 4 myomas we will remove, and I think Durga will understand. Whenever they send me with scan reports, I'll say I'll do an MRI. MRI also gives me an idea about such adenomyosis associated with endometriosis, which gives me a further counseling point to patients. See, you have adenomyosis. I may clear your endometriosis, but you must still have dysmenorrhea. I cannot manage that unless I have time. So I think it just gives me a little bit more counseling points to patients by showing them their topography of their pelvis, and that's what I actually use MRI. I wish I could have Dr. Praveen all the time with me to do my scans. But
No, not that way. And then your question about ureteric involvement.
yeah.
Basically, when you are... Yeah, I
doing everything from
I know. When we focus on the anterior compartment, that is basically the bladder, there are bladder deposits which can be easily picked up.
Yes.
And not only that, the location of the bladder deposit is extremely important because whether it is causing obstruction to the ureteric flow or not, that's one. Not only that, when you are doing the bladder evaluation, along with it, if you put the color Doppler on, you will see a ureteric jet pushing into the bladder. Once you know that you have seen the ureteric jet pushing into the bladder, you know that the ureter is No, it is not.
Yeah.
No, not only that, another important thing is because it is ultrasound, I can shift to the transabdominal and look for the kidneys.
Actually, you should.
Yeah.
You should never treat a patient with endometriosis just with a transvaginal scan. Make sure the probe has been put in the abdomen and documented that there is no hydrouterine nephrosis. Because you will operate, and 6 months later she comes with the report saying left side hydrouterine nephrosis, and they'll say there's some gadbad in the surgery, and now my kidney is going. So in fact, patients, if we find severe amount of hydrouterine nephrosis, we even sometimes do a scan to show what is their kidney function. Because I don't want, we need to document just like we do AMH before it. So you need to document how much is the kidney, because silent kidney loss is not unknown in endometriosis if we don't look for it.
Yes.
Yeah. Okay.
And
So
regarding the sigmoid, there is a specific technique to evaluate the posterior compartment. What we need to do is we need to come out and focus your transducer towards the posterior compartment, that is the posterior phalanx, and magnify the image. See, that is one most important thing that we always try to avoid, but then when you magnify the image, all the layers of the rectum or the sigmoid can be very beautifully demonstrated, particularly with the present generation transvaginal transducers.
okay, one question before we even progress. In these cases that you have been doing transvaginal, how many patients do you think percentage-wise or your experience have a transmural involvement of rectum or sigmoid? From mucosa to serosa.
Yeah.
How many do you find?
No, I mean hardly.
Exactly.
Hardly.
Actually, this is what we were talking over lunch as well with Dr. Pasak and Dr. Partha and maybe Dr. Manjula also, that unless there is a transmural involvement from serosa to mucosa, a very aggressive bowel resection is not required.
Detrimental, it is detrimental. We are seeing more and more people doing discectomies and doing end-to-end this. It's not
I'm glad this
necessary.
point is coming up.
Especially with medical management, just doing the excision of superficial lesion with followed by good medical management, the patient quality of life. Please don't end up with dehiscence and
More morbidity.
More morbidity.
How many
please.
patients did you need to do end-to-end resection?
Only one in my life in 25 years.
Me too, only one. Dr. Savita.
Only one.
Exactly. Any other one, somebody wants to share how many end-to-end bowel resection or detailed bowel resection did you need to do in your
There was
research?
a center from Sao Paulo, I think.
Don't talk about those centers. I don't want to talk about those
India,
centers.
South India, especially I'm talking about. We do not have such aggressive thing what we see in Calcutta. Calcutta we don't see
No.
aggressive. We do see
No,
aggressive.
let's not regionalize. Let's not regionalize. We are just talking about each surgeon's experience here. No regionalization here.
No, I'm not being racist or anything, but yes, certainly
No,
these are
Okay, we need to progress
some
now.
areas.
All right. Okay, let's progress now. What happened to my slide? Not coming. Okay. All right. So now endometriosis and bowel come together very often because they are involved. Full thickness disease without bowel dysfunction is very rare. Okay. Very few patients you will find that they are having actually bleeding in stools, right? They will have very severe pain. That is, dyschezia is there, but you will never find them. Many times if they say that, they might have just a hemorrhoid or a fissure. Long-term manifestation of a bowel resection, we must remember. And endometriosis, can we think of it as an oncological disease? I'm going to now throw a googly. Do we think that this we can use it as a, say you use medical therapy or GnRH as a new adjuvant before you operate? What is the take of the surgeons here?
I tell the patients it is like cancer but not cancer. That is the first
So
statement.
do you adjuvant?
New adjuvant, if there is no endometrioma and or adenomyosis where it's going to hamper my disease, I can still think of it.
Do you
but by
believe
the
by
time most of
doing
the patient comes to me, they are already on medical management and then come to me. So I do the surgery and then again medical management.
Okay.
Sandwich therapy.
Do you believe that giving GnRH before your surgery will make the smaller lesions disappear and reappear after your surgery?
It happens especially with myoma.
Partha, Dr. Partha, do you want to do that?
It does. I don't think that is because the small lesions disappear, and I will not find them they're shrunken out. So I don't think there is any.
So that the final jury is not out on that, but I think it's important to think about it. And as we said, it's a neighborhood disease, so bowel is involvement very fast. And we must remember, especially when endometrioma is present.
Yes.
Don't think you are going in just to remove a cyst. Bowel will be involved. You have to be prepared. The patient has to be counseled and then say that we are going to do that. Okay, so that's very small. It's in close proximity, so that gets involved. So this is one small clip on how we do our robotic hysterectomy in patients of advanced endometriosis. You'll find the link in the journal, in the update, which we'll share. So see there. I'm not going to waste your time for this surgery right now. Now we'll come to case 2. Now case 2 is a 38-year-old, married for 10 years, primary infertility. She had 4 cycles of IUI and 3 cycles of IVF failure. This is a direct question for Dr. Durga now. She has regular cycles, moderate flow, dysmenorrhea. This is her clinical pelvic examination. Cervix is healthy, uterus is about 8 weeks, so probably there is adenomyosis as well. Anterior fornix, we can feel mass, they are non-tender. Uterosacral ligaments very taut and tender, left more than right, and uterosacral tenderness VAS score was 4/10. She doesn't have any PR bleeding. She tenderness and fixed nodules there, more towards the left. So when we saw in this patient, we found a nodule somewhere here. And there are something that we felt anteriorly. We got a scan done. Scan says 2 fibroids in the anterior segment. This is the MRI further that we did. There were 2 fibroids. Dr. Durga, this patient is infertility and you want us to do something about her. Would you just...
Particularly because
This
she's
is
had
important.
3 IVF cycles before and they have failed. So we really need to know the failure of that. Is that because of the uterine pathology that she has, or is it more of the embryo?
So do you think these 2 fibroids that were hanging in the anterior segment, lower anterior segment, could have been the failure, or how would you?
It could have contributed to the failure. I wouldn't say this could be the only reason, but yes, because obviously looking at the fact that they are at the lower segment, there could be motility as well as other issues that could have hampered or impacted the implantation. So
Okay.
yes.
So the next question to you is, in such patients with fibroid which are not really, classically we say the fibroid is in the submucous cavity, they are the most notorious one for causing infertility or implantation failure, whatever. But fibroids who are, say, grade 5, grade 6, FIGO 5, 6, are not impinging in the cavity, but they're hanging there. How do you think is that directly responsible for infertility or your IVF failure?
So when we are talking about fibroids in the position, you rightly said, when it comes to, FIGO type 0, 1, 2, definitely needs treatment. Even from 3 to 5, this is where we are still not very sure whether we are doing the right thing by going for myomectomy or not. But then we have to look back at the history to see whether, she's had transfers or she's had embryo transfers done wherein the fibroids were in the position that they are without actually impacting the uterine cavity. But if they have not implanted, then we should be looking at doing myomectomy. Now that's the reason why the first option is always that, hands-off approach. Try to do it if it's anything 3 and above.
So you think it was justified for her to have all this?
After 3 failures, definitely.
I would like
No.
to add one more sentence.
No, she was justified to have this IUI and IVF beginning day.
Absolutely.
Absolutely. So how many of you, hands up, if you had a patient like this before she had these failures, would have attempted a myomectomy? Audience poll. How would you think? Patient is up 4 or 5 years, married, not conceiving on her own, comes with a scan report of 2 fibroids in the anterior segment.
I would rather put it like this, ROOMA. I would like to do a laparoscopy because she had 3 failures IVF and 3 failures IUI. So definitely you would need to have a look and see if there is a grade 1 or grade 2 endometriosis. And anyway, since I am there, I can as well do a myomectomy because it's such a simple task.
So, and I want to add one more sentence.
Okay.
The presence of, even it is 3, 4, 5 fibroid, just the presence of fibroid is an irritant for implantation.
Yeah.
So when it is a failure, then we just
Not agreeable at all. Not agreeable.
No, not irritant. There is
no
If
evidence
it can.
No, absolutely not. There is no evidence to suggest that and fibroid can impact implantation. There is absolutely no. In fact, even with submucous, they are saying that you have to be careful because the way you do the surgery, you might actually have an advantage because of the fibroids. So fibroids being an indication, infertility, not there.
Yes.
So we are not talking about zero.
I like this discussion. Carry on.
Just the that is the reason. Exactly, the presence of fibroids is not a reason for surgery.
The failure may be taken.
That's right. That's not not for the
Okay. Time up. Now.
Can I just
Please,
intervene?
please.
See, the thing is, issue is that here we are talking about a lady who has been trying for 5 years. She has had multiple failures. We got to give her some success. So, in order to do that, if we are embarking on surgery, which I believe at this point should be done, now there is enough of evidence to say that even if it is a mild or minimal disease, doing a surgery, you might ask me what is the value of peritoneectomy. Well, if you do a peritoneectomy, then you are increasing her chances of spontaneous pregnancy. But then, whether you are going to actually increase her chances of IVF success, we still don't know, but probably it will increase. I have a problem here. If you look at the junctional zone, she has a problem. Looking at that, she has got adenoids. Why are we not addressing that? Can we do anything about that?
Actually, the 2 lesions, one is very classical of a fibroid, but the other one, which is on the right side, is definitely an adenomyoma. It's not a
Sir, this was just in my theatre a week back. My residents are here. There were both fibroids.
No, there is one fibroid. This one.
No, they were both fibroids, sir. We have removed it just 1 week back. I don't know whether we saw the pathology report yet.
And even if
Anyhow, my question, my idea of bringing this for the point is here is this: would you suspect a clinical endometriosis in this patient? Because there is no imaging evidence. Only in my digital examination I found some tenderness in the left uterosacral area. So the question arises is that I take a consent of myomectomy, I go in, I find peritoneal disease. Do I resect or I don't? Because I'm not taking counseling. So should we go in with counseling of this? Because supposing I start doing peritoneectomy and I do a ureteric damage, possible? Possible?
Absolutely.
Right? I have not taken permission. Since why did you touch my lateral pelvic wall?
You
So
can't.
what counseling should we do?
No, you can't. So that's the reason that, even if you are
This
taking,
was her
there is nothing called a diagnostic laparoscopy nowadays. I mean, we have gone beyond that. If you are doing a diagnostic laparoscopy, please counsel that you could have this, you can have that, and this. I even go to the extent that if you have a bowel endometriosis, you might land up with shaving, you might land up with colostomy.
Correct.
If they go away, some people have said, why do you say that the patient will run away?
Let them run away.
I have got no problem.
Yeah. These are the two fibroids we removed, and once we removed the fibroids, that was her lateral pelvic wall. So, now question again to Durga. What is the crosstalk between peritoneal disease, superficial peritoneal disease, and fertility failure? Not just I'm talking about your IVF failure, but in general, spontaneous fertility failure or not able to conceive. Do you think this peritoneal disease is causing that?
It is definitely contributing, which is why when we are talking about type 1 and type 2, why are we saying that, when you're looking at it, why don't you treat it? Because you at least are giving the woman a chance for a natural pregnancy, by actually eradicating the disease as much as possible. So coming to this, even though we have had fibroids here, the question initially when we were saying failures, frankly, whenever we see fibroids, if they are type 3 and above, we will also consider the fact that with the junctional zone and the ambiguity between whether it is a fibroid or an adenomyoma, we do tend to downregulate them. Downregulate them for two reasons. One is not just for the fibroid shrinkage, but also for any kind of inflammatory conditions that are usually prevalent in people with previous failures. So in this woman, definitely myomectomy plus looking at.
Okay, the question to Dr. Manjula, I think she's showing something to Dr. Savita, never mind. Okay, this was the picture I showed, right?
Right.
Now this is her lateral pelvic wall.
Yeah.
Okay. What would you do?
Definitely peritoneal.
Okay.
First of all,
Ma'am, would you agree to any cauterization?
Superficial cauterization, if it's more than 5 millimeters in depth, I'll do the peritoneum.
How would you know
I
by
will
looking at it it's 5 millimeter or not?
I would give a vasopressin.
Catching hold of the thing, you can make out how deep it is.
Okay, first, in continuation of what you said, I would give a vasopressin beneath this layer and then do a peritoneum.
Okay, that's your technique of doing peritoneectomy, but I wanted opinion. So, Dr. Partha, what is your take here? Would you do peritoneectomy or would you just do superficial?
Superficial will not help probably because if you really want to do something,
but for both, either you want to do superficial cauterization or you want to do peritoneectomy, look for the ureter first. Identify, dissect, lateralize, and then do what you want. So in this particular patient, we actually went ahead and did peritoneectomy of the left side. This is actually another case in which I'm just trying to show that we were doing the right side because it's not always on the left side. This is a robotic surgery, that's a laparoscopic surgery. But as point I'm trying to make here is, especially for the residents and the fellows, that always identify your ureters at the brim. Once you reach this area, you will not be able to identify the ureters. So make sure you have identified the ureter. And on the left side, the step before that becomes reflecting the sigmoid. You have to reflect the sigmoid to be able to reach. And depending upon what tools you have to identify, see the ureters. The best way to identify the ureter is the peristalsis as well as the vascularity over it, which is like a mesh. And between these two, you will be able to identify ureter most of the time. These are peritoneal disease, and I think the jury is out today that peritoneal disease has a crosstalk with infertility, and presence of this with cytokines and all the other inflammatory markers reduces the spontaneous pregnancy rate as well as implantation rate. True? So, Dr. Durga, if the patient, like this patient, after I have done this, she's already 38 with so many failures, should I send you back to do another IVF or should I now tell, okay, I've removed your peritoneal disease, so try spontaneous pregnancy?
Please.
What should be my take here?
IVF with obviously PGT, down regulation, then transfer the embryo.
Why do you say so?
Okay.
What's your logic here?
38.
Okay.
She's had 3 failures.
Okay.
And she had failures when she was younger, obviously. So now age is one factor for her to do PGTA. Second, down regulation, because even though you have done peritonectomy and we have done the myomectomy, there's still obviously disease which is not being visible and which you obviously have left behind. So we will go ahead and do the down regulation with GnRH.
So
Particularly because of your inflammatory
Correct.
markers.
So very important factor of using GnRH in such patients. We almost always give them post-operative one sort of glycerin or anything so that they downregulate and then maybe go in for him. So one cycle is, I think, almost mandatory. I think what Dr. Krishna Kumari, would you like to comment here? Would you like to give downregulating something all the time?
Yes, after the, I think definitely after the...
Even if the patient is looking for fertility.
Right.
Right?
Right.
This is again another very classical feature. Just I brought this. Yes, I just brought this for most of the residents and fellows. And if you look at this very carefully, you'll find these are peritoneal pockets which are actually pathognomic of endometriosis. If you resect this, you can actually in this particular this you can find the ureter right here peristaltic under it. Okay. So again, don't think it's a master, so I'll just resect it out. Look for the ureter, look for the ureter, look for the ureter. Just like in the aircraft, they will tell you, only evacuate, 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 then you open the door. So you open your endometriosis surgery only when you have looked for the ureter, looked for the ureter, looked for the ureter. So that's the surgery.
I think Dr. ROOMA, the paradigm of doing surgery in endometriosis has changed completely. And nowadays our approach is from the left side, left pelvic brim, and it is retroperitoneal.
Yes.
So even if you have to do an excision, your ureter is just in front of you all the time.
Yes.
Because you have entered the retroperitoneal space, you have lifted the peritoneum up, and you are doing the dissection. So there is no way you can actually injure the ureter if you stick to this golden principles of retroperitoneal surgery.
So these are some other examples where you find endometriotic deposits above the pelvic brim. Of course, you can go up to the diaphragm, but this is in one patient recently that we operated. We found these peritoneal deposits right there at her anterior abdominal wall above the pelvic brim that we have resected out. So we will now come to some medical therapy. Now, clinical endometriosis, I think when Dr. SUPARNA was also talking, there is no confusion. There is absolute agreement by various endometriosis societies that if you suspect clinical endometriosis, medical therapy should be started, right? Dr. Partha, what would be your first line of medical therapy? Clinical endometriosis.
Yes, first are progestins, obviously, not GnRH analogs to start with the progestins. And obviously now that the anesthesia is there.
Which progestin is your favorite to start as a first line?
Would you start?
Dianogist, fourth generation? Okay. Dr. Krishna Kumari?
I think it is based on the symptom and the age which she presents to us.
Okay.
So if the symptom is basically pain, even you can start with the basic NSAIDs and then move up along with the progestins, OCPs. Actually having now they're talking about estrogen threshold. So if it is less than the threshold, low estrogen, when it is there, the progestins and estrogen combination works better than pure progesterone. That is also one school of thought which is there. So giving OCPs is my favorite, the next step. Then of course we always have the more older they grow, where we believe that there is a estrogen dominance. Probably we are moving towards LNG-IUS, especially if it is a rectal pain and something suggestive of dysgeusia. All these things, I think I prefer LNG-IUS. But even with LNG-IUS, it better works when we give it with norethindrone. And if you have nothing, if you are working in a government or a college setup, you can also give injection DMPA, which is very cheap. But remember about the bones.
Okay, I have one question to Dr. Durga. 1 minute. I just want to have one because this has been on my mind along. You have a young patient, say 18, 19 years old, and you clinically suspect her to be endometriosis. We first line give oral contraceptive pills. Do you believe that this will help reduce her progression, or we are just giving symptomatic? Agreed. Again, let me revise this question. Do you think by keeping her anovulatory, we are saving her follicles?
See, endometriosis in terms of saving the follicles with the pill,
yes.
The answer is yes. You are at least reducing the progression.
Yes.
You know, so the main point about endometriosis when it comes to fertility is the first surgery that you do should be the last surgery.
Perfect.
Which is why when we were talking about the progression, it has to be her symptoms followed by examination, followed by a very good transvaginal ultrasound. I would even suggest MRI, though we might have a difference of opinion there only because that if you're going in, there are certain areas which are not obviously visible. And if you're going in for surgery, you might as well clear the pelvis as much as possible.
I totally agree. That is why so much we prepare so much ourselves with information and counsel the patient that we are not going to leave the battle halfway.
Because repeat surgery is an absolute no.
And that is the reason why, if you feel you cannot do, don't do.
Yeah.
That's really a very, very honest appeal to everybody for the patient, for not anything else.
I want to add something to what
Carry on.
Everything depends on symptoms and age, like we all discussed, and the surgical status of what we have done. So like Dr. Krishna said, in the younger age group, like Dr. Partho said, it is gynecologists or OC, this is what is the medical management. Post-surgery, definitely before going for IVF or everything, it will be GNR channel. Or again, if she's not thinking of pregnancy, then LNG IUS. But what we should think of is aromatase inhibitors, especially in the perimenopausal age group. Because post-hysterectomy, we know what endometriosis, what adenomyosis also have seen. So post-hysterectomy, my drug of choice is aromatase inhibitor for at least 9 months, and then I will.
Perfect. Would you also explain the logic to our students?
So we know
Why we are giving aromatase inhibitors?
Yeah, basically we are looking at suppression of the estrogen, which is the main culprit for what. But now we know it is not just the estrogen; it is the abnormal progesterone activity. It is a receptor which is at fault.
Resistant.
So it's resistant to the whatever progesterone we are having. So the first drug of line has always been. Lot of trials have been done for aromatase inhibitors, even for younger patients, especially when we are doing any hysteroscopy. Also, but we have realized a lot of side effects in the form of, again, the hot flushes and everything is going to be there. So we look at perimenopausal age group, where again automatically the natural estrogen activity is going to be less, and postmenopausal where it is there, where they're completely stopping the HPO axis. Locally, this is going to be more effective than the HPO axis.
So let me put it in a nutshell. Between the main difference between a utopic endometrium and an ectopic endometrium is the aromatase. So aromatase enzyme and aromatase activity is higher in ectopic endometrium. Although use of aromatase endometrium is right now off-label. It's not approved.
Yeah.
We do use it, and I think my choice of using that is, of course, in a postmenopausal or in adenomyosis.
So what is the dose that you use?
2.5 daily for about 3 months.
Twice a week or?
No, every day.
Every day.
Or 2.5 every day for 6 to 9 months.
Yeah.
So because why I asked
Calcium and vitamin D, please don't
there
forget.
is a new study which says that twice weekly is also as effective as
Okay,
daily
then
dosage.
share that information with
And
us.
six months is something
Okay.
they are
6
looking
to
at.
9.
6 to 9 months.
Dr. Samita, do you have experience in using aromatase inhibitors for your patients? Or you don't use that? Because it's off the label right now, so it's okay if not used.
Yeah, we use Dynogest mostly.
Okay.
In fact, when we were talking about downregulation, we tend to go for a 3-pronged approach, because as you can see, most of them do tend to have a very disordered endomyometrial junction. So we use Mirena, we go for agonist as well as letrozole, because 3 of them have different ways of action, and that's how we actually downregulate before we go for an MPH.
Okay, how many months do you use this downregulation?
A minimum of 3 months.
Yeah, that is what
And what is what are
Minimum
the
3 months.
What are the parameters or the clues you look at the end of 3 months and saying, okay, we have downregulated enough?
There are none. There are none. No. Sometimes you might see myometrial cysts, endomyometrial cysts, but the problem with them is they might collapse with all of this management. But once you're going towards your preparation of the endometrium, you might see a
thinning and all. Lot of studies are coming out for letrozole, for pre-hysteroscopic thinning. Lot of things are coming for postmenopausal and all. I think time will come.
So I think most of this medical therapy, either we use a short period for downregulating or we use it for long term for pain management. I think this is the crux of it. We can use GnRH analogs, but the problem is you can use it for 6 months, put it up to 9 months or maybe 1 year, because there are a lot of other add-back therapies that you need to add. Danogest is a good, it has come to our rescue, 4th generation. Norethistron is very good because it has a very, very specific action. Because it downregulates the progesterone. The resistance of the progesterone in this ectopic endometrium is reduced and it affects there. Oral progesterones, like anything else also, you can use LNG IUS is again one of my favorites. If I do my conservative surgery and patient doesn't want a pregnancy, I will always put in, although we sometimes have a lot of patients coming back with this bleeding, that bleeding, you have to counsel them. And of course there is no way to have one...
One thing I wanted
Sure.
to ask is, ask rather than state, is when we are using this specific drug OCPs, the advantage of why I prefer OCPs and progestins is long-term usage. Whether you're using
Absolutely.
norethindrone or whether you're using LNGIOS or OCPs. But when we're using the other things, all the studies are very limited, whether it's GnRH agonist. Of course, now I hear about GnRH agonist with BMD regularly being done and being used for 14 years. That also has come up as a study. So I don't know how much logical it is to use it.
Progesterone to GnRH analog. That is another study.
Yeah.
So I think we are constantly evolving in our way we look at endometriosis, what we can do to make quality of life of these patients better, and of course give them fertility if we can, because I think more than fertility, although patients will come and say, okay, we are looking for fertility because that's the desperate situation, but if you just look into their eye, you will realize what is their quality of life. Sometimes it is really sad to talk to them, and the years together they are suffering, not able to vocalize their quality of life issues because they are going on with the fact that they must have a fertility. We must help them in all possibility. And of course, what agent you choose, what therapy you choose will depend upon, of course, the patient's age, what is their symptom severity, what is their desire at that point of time. And that's the first question I ask to my patients. What have you come to me for? What do you want me to solve? Do you want me to solve your pain? Do you want me to solve your fertility? And then I will get into my action to do what, right? Dr. Prasad? Yeah.
Right. So I think in your last slide, you had shown about the medical treatment and you had mentioned one point as post-operative. I think that is a very important area that we sometimes miss.
Okay.
Even if you do
Why don't
the
you
best
highlight
of the surgery, if you've done a radical surgery, even you should give Dynagest or something of that spot suppression. And if you have done a conservative surgery and you've removed most of the lesions, then also think of putting in a LNG-IUS unless the patient is going for a infertility treatment. That is a different paradigm altogether. Then we are not going to give medical treatment. But for recurrence, I think for prevention of recurrence, medical treatment is must.
But Dr. Durga will agree with me. Even for a patient who is looking for fertility, even if you have sent me a patient who has frozen embryos, I'd still like to give her 1 dose of glycerolin before I send her back. Right?
Absolutely. So would we.
So don't hesitate in giving 1 dose and give that 3.6. Don't give that 11.5. Give that 3.6 and then we take a call on it.
Because we have to not forget that it is an inflammatory condition. So we have to treat them.
You cannot be egoistic and saying, okay, I cleared everything, it's just
I just want to say one thing about counseling to the youngsters. What we say is, what the eyes can see, we are removing. What the eyes cannot see, we are suppressing using this. So unless we tell them, they will not understand why we are again doing it.
And many times you have to stop short of doing everything because the nodule may be just sitting on the ureter. It's either removing a part of ureter or just shaving it off and saving the ureter, because see, giving a ureteric reanastomosis is a much more moderate procedure to the patient than giving a suppressive therapy, right? So you have to take the right call at the right time. Anyhow, so case 3, we'll finish fast now. Okay, 34-year-old unmarried girl, severe dysmenorrhea, menstrual bleeding for 10 years, which has increased in the last 3 years, pain in the lower back and abdomen radiating to leg, refractory to medications for the last 3 years. 3 years back, her ultrasound shows a left endometrioma of 5 into 4 centimeters. She was on Dynagest for 18 months. 3 cycles of GnRH as well, but now her ultrasound shows a very large endometrioma of 13 into 10 centimeters with the right side about 3 to 4 centimeters. She has, of course, associated vegetative symptoms like bloating, defecatory difficulty, and extreme fatigue. When we put in our scope, this is the large endometrioma. Dr. Manjula, have we done right in putting the scope?
Yes, absolutely.
Take an audience vote, not one.
Okay, audience vote.
Yes.
Half of them are our students, they'll say yes because I already did it.
Everybody should know what is the cutoff point. Like even in IVF, they say 3 centimeters is the cutoff. Or
We can have a cutoff,
Yes.
but we have to treat the patient first.
Yeah,
so
yeah,
somebody with that kind of
definitely needs it.
She needs it.
Okay, so again I will go back to the point that Dr. Durga made. First surgery, right surgery, last surgery,
yes.
right?
Yes.
So when to operate and when to observe. In case of endometrioma, from a pain point of view, I want Dr. Savita to say, and from infertility point of view, I want Dr. Durga speaking in. So Dr. Savita, patient has come with pain, no fertility issue right now. You diagnose an endometrioma, then you will wait when you will operate.
The size of the endometrioma.
Okay, size is one thing. So what is your cutoff side for you?
5 centimeters.
Okay, great. I think that's a very important. So if there is patient having an endometrioma of 5 centimeters, how will you decide I'll observe or operate?
Well, it again depends upon the age of the patient and.
She's just come for pain. We're not talking about fertility. She's just come for pain. Any age. Fertility not issue to me right now.
Okay, pain, even if it is pain, we can try medical treatment for a while.
Do you
and
think
see.
the medical treatment will reduce the size? Have you seen giving
No.
medical?
Of course, gynecologist it can reduce to some extent, but
Dr. Parth, have you come over?
but there is a very good pain relief with gynecologist.
Yeah,
They
it's
have
pain
excellent.
But it doesn't
See,
make the
Roma-
disease disappear.
Roma, I will discuss the options with her. I will not decide for her.
Okay.
I'll tell her, see, it is like this. Either you will be under very close observation, we'll keep monitoring, and then we will give you the medical treatment and follow the pain, your pain scores. That is one option. The other one is if it is more than 5 centimeters, or borderline, we are saying.
One more dilemma at this point. 5 centimeter, patient is in pain. I will ask for other symptoms to give me a clue regarding DIE. Okay? Do you think operating will help reduce progression, or giving medical therapy at this point will reduce progression? Because progression is important to me, right? These patients may progress. She's not talking about fertility right now, but she'll come in 3 years and say, "No, I want fertility." So, do you think we should operate so that we can reduce the progression?
See, this is an area, I mean, when you're
I know, I'm
talking about a
asking
patient
all the questions which come to my mind when I'm the patient.
who is sitting in front of you, you have to, I mean, we can say we are giving options. At the end of the day,
Yes, sir.
you have to take, you have to take a decision for them. But the thing is, issue is completely taken. Your, points about age, how long she's having the pain, and then her concern for fertility. Now, if she's not concerned about fertility at all, if she's having pain, which we have tried all medications which has failed, I think she's a candidate for surgery, and it is not a surgery for endometrioma, because we are missing something here. If we have,
There will be a lot of peritoneal disease.
they will have peritoneal disease. I can guarantee she will have a retroperitoneal DI and a retrocervical DI,
You
and
said the
probably.
word failed medical treatment.
Yes.
Yes, initially we will try the medical treatment.
And the problem is not there. I mean, I have lots of patients whom I think I've done the best of surgery. I was very happy. They come back after 3 months, the same pain.
I know. This is very frustrating. That's why I'm asking all these questions. So, do you believe that if this patient failed medical therapy, by doing this surgery, we are definitely taking care of the pain? Are we preserving or preventing her recurrence or progression?
We definitely.
Okay, so you feel that excising the endometriosis and then putting them medical therapy will work better than straight away putting only on medical therapy? Is that the opinion of my panel or audience?
Yeah, definitely my opinion is definitely that.
But I would take it like this. Supposing this is a 23-year-old girl who is not yet married, I would suppress her pain by medical therapy and wait for 3 years when she gets married, and that time I will operate so that she has the golden period for conception as well.
23 is not her, if she is 17 years old.
Of course, I'll come to that 17-year-old girl in a minute. I will come to that patient also. And then I'll take your opinion, Dr. Partha. Wait a minute. Okay, so I had one small video mainly for my fellows here talking about how you classify the endometrioma, because you should know how the different endometriomas look like and which is the easy to peel and which is not the easy to peel. So you have type 1, which is this one, which is the invagination of the cyst inside the ovary. So the ovary becomes like this, and the peeling is very difficult. But then you have the type 2, which is a hemorrhagic cyst, which later on turned into, you can find this kind of cyst very nice. You have the surgery, excellent, because there is no adhesions, a nice little cyst. You do an excision, and then you can find a different type of peeling in this. So peeling becomes very easy. You can inject vasopressin, get the peeling off, and it becomes quite easy. But then you have type 2C, which becomes like type 1, where peeling becomes very difficult. These are the patients you have to be very careful. Now, how would you prevent ovarian reserve, Dr. Manjuna?
I would definitely, my technique is again vasopressin injecting. There are some types. First is, if you are near the hilum is the point where you need to be very careful. So you can use a combined technique of excision till that time and then ablation at that time. Ablation at that time. That is one thing. Donna's 3-step technique is also there, where you can go and then just aspirate, come out, again do laparoscopy, give GnRH and again do laparoscopy and remove. That's over. The next we have is the vasopressin injection technique, where first when we elevate, like Dr. Arnab said, we come from the lateral pelvic wall and lift the endometrioma. The least wherever the least resistance, it opens up. That is the avascular zone, so you don't have to be using the energy source. Then we go into the cyst wall, we give a diluted vasopressin, which acts 2 ways. one, hydrodissection of the wall away from, means least number of oocytes or the reserve is going to come down. Second is the amount of the bleeding is less, and naturally we are not going to use any thermal injury to that, leading to that. So because of that, we just will be removing very easily the whole line. Even if I see what she said, even in that cases it will be quite easier for us to completely peel off the thing. That is the third technique. The fourth would be, again, which Dr. Savita madam told about aspiration and giving the alcohol, or sclerosis using ethanol alcohol, or methotrexate also. People have tried methotrexate. So all these four techniques.
So two things, remember.
One
to be in the right plane.
One more technique is that if at all there is an exact active bleeding happening after you do the surgery, you could just put a Surgisil or gelatin fibrin or thrombin and then come out without going on burning.
Yeah.
I think one more thing that has come up in the recent years, that is, you just drain the cyst, clean it, and then if you have a diode laser, because previously people used to use carbon dioxide, but if you use a diode laser on the wall, it will it's an ablation where the depth of penetration is not more than 3 millimeters, and that is where you can preserve most of the follicles. So that is another technique. We don't have a diode laser, but people centers who have.
And there are also studies with ablation saying that, with laser saying that more fibrosis is seen post laser. So I am not a fan of.
Be in the right plane. Don't use too much of cautery. Be careful at hilum, because it starts bleeding in hilum. You have to use cautery and don't suture. That's my thing. I don't suture.
Yeah, suturing is something which can lead to more adhesions.
Yes.
That is,
and it can also reduce your blood supply to the ovary. So don't suture. Ovaries form very well. And this is just to say that we have actually started doing a lot of these endometrioma resection with our robotic technology. And we find that giving very short burst of a monopolar energy with a very low setting, going into the right plane, reduces the oozing in these patients, preventing me to use a lot of bipolar cautery in these patients. So we have already discussed that. You'll find this paper again in the endometriosis update, which we will get. Now, Dr. Durga, any patient of endometriosis, at what age would you, or what are the factors which will make, if the patient comes and says, should I freeze my eggs? What are the factors you take into consideration saying, yes, you should?
I would say anybody who is looking to postpone her fertility beyond 33 or 35 needs oocyte vitrification. If you're talking about endometriosis in particular, it doesn't matter what age they are in. I think we sometimes shout it because she's 17, why does she need it? But the issues that you have to consider for oocyte vitrification is bilateral disease, obviously, and something in which the recurrence is very quick.
How do you know the recurrence is going to be quick?
Yeah, that is somebody, now suppose she comes with pain and you're doing laparoscopy. Okay, you have treated her pain for that time. And then after 3 months she comes back again with another endometrioma. Obviously the recurrence is higher, even though you have done a clearance surgery. So in people like that, even if they are young, recurrence is there, which is much bigger than somebody else, definitely would be considered for.
So would I be correct in saying that when we have young patients who are not yet thinking about fertility, married or unmarried, should we be asking them for one counseling by somebody like you in terms of oocyte preservation?
I was hoping
Dr.
that.
Would you send all your patients like this?
I
always send. Dr. Partha, would you like to send such one? Yes. So I think the technique and the thought process in oocyte retrieval and freezing is of age now.
Yes.
Correct? And I think we will be wrong as doctors if we are not offering them to our patients. At least we should counsel and discuss that.
I think that should be one of your focal points when we are having awareness, when we are talking about endometriosis and awareness. The awareness, though people do understand surgery and medical therapy, is there.
But this is the most important awareness. I believe it.
Yes.
Yes, I believe it.
And
That's what
it has to start at adolescence.
Correct.
It's the most important period that you look at.
And this is the point.
Especially with endometrioma, there is also, even without doing surgery, we say that the ovarian reserve will come down when you peel off the cyst wall. But even without doing that, there is a study called ERROR study, endometrioma related reduction in ovarian reserve.
Yes.
So just because of the presence of endometrioma also the number
because we find so many patients before we operate, nobody has touched them, AMH is still 0.2.
Yeah.
Right?
So definitely we need to advise them.
Correct. So I will come to almost the last of my discussion and bring the elephant in the room, and that is the adenomyosis. Right now we have this patient, 18-year-old girl, severe dysmenorrhea, 6 months, heavy menstrual bleeding, She's approaching board exams, managed by analgesics, associated symptoms, all of them are there. Ultrasound says diffuse adenomyosis of large uterus. She's begging for a hysterectomy. This is her MRI. Why question number 1 to Dr. Arnab, because he's also doing some research. Why do you think an 18-year-old girl has this adenomyosis? It's really, it baffles me.
See, this is, I think, one of the dreaded challenges in clinical practice, and all of us have these patients. The problem that she has is a chronic pain syndrome. And what do we mean by chronic pain syndrome? She has a noxious stimulus. You can all see that, she has got an inflammatory pathology, which has caused two things. One is it has caused peripheral sensitization, and it has caused a central sensitization. I think we have to understand this before we go and treat this patient.
Perfect.
If the noxious stimulus is there persistently more than 6 months, you have two things which is happening. Pain is a experience, it is a sensation, it is processed in the brain. And in the brain, these higher centers, they receive this signal from the sensory neurons. Now, at the local side, these sensory neurons are being stimulated by this inflammatory cytokines or whatever peptides you say, and they develop what is known as two things. One is the viscerosomatic convergence and viscerosomatic, sensitization. So what happens is, when you want to stimulate a nerve, you have to give a threshold, stimulus. In this situation, because there is so many changes happening in the receptor level, a sub-threshold stimulus stimulates this, and this signal goes to the brain. The brain has now changed its way of processing. So the suboptimal signals it is started processing. So two things is happening. One is hyperalgesia and is allodynia. What is hyperalgesia? Small stimulus which you would not have felt. This patient feels tremendously.
Yes.
So that's why any sort of signal coming from this pelvic area, she is it is amplifying in the brain. So she is getting a lot of pain. What is allodynia? It may not be a noxious stimulus, just the act of touching, it gives a lot of pain. So she is having this central sensitization, which is the brain which has processed it, and she has got a peripheral sensitization which the nerve fibers have processed it. So she is in a complete...
Very true, Dr. Arnab. It's actually very difficult. So let me just cut the story short for this little girl. We actually managed her with painkillers. We actually even put Marina. We had a psychological help. We put her on antidepressants. She actually is better. She finished her exam. She's an engineering student now. But I know how much counseling I need to do. Not just physically on phone, midnight call. But I think these young patients, because I cannot do hysterectomy. The question is, can we do something for her disease? Or this disease?
I think this is quite a big 14-week size.
Yes.
So definitely GNR 14 centimeter. Yeah,
14 centimeters.
That is almost the same. So
it's a large class. 18 years old girl, I can't give GNRH.
Yeah. No, I know.
Dynogest. So she's on Dynogest.
What I was supposed to say is GNRH with Dynogest, and after 3 months stop GNRH, continue with Dynogest. That will be.
I'm just keeping her GNRH till she turns about 20, 21, and then I'm going to get
the
the
cutoff. 18 is the cutoff now. 18 ke baad we can.
By 18, they said the
Bone is peak max.
Perfect. So I'm going to twist this patient. 4B. She's now a 26-year-old girl, not the same girl. Married for 3 years, intractable pain with heavy menstrual bleeding. Primary desire wants conception. But secondary desire, I look into her eyes and say, I cannot bear this pain, ma'am, do something. This is an MRI. Dr. Durga, you want me to send her to you, or you want me to do something? Let's put it very plain here.
So she wants conception.
She wants conception. And this is the large diffuse adenomyosis.
She has to make a decision. I know, with the husband next to her, she'll say fertility. But, when you're doing the scan, you can understand that she's in a lot of pain. So here again, the question is, if it's fertility, even if it is fertility, with this kind of adenomyosis, it is going to impact her implantation anyway. So I would first treat her adenomyosis.
So we should treat her medically? That's what you say?
I would say medically, absolutely.
Okay. So what is, supposing medically we treat, and I think we got this point from Dr. Suparna, which is talking about limited your embryo transfer catheter and you cannot reach the fundus. So do you have any cutoff point to say this is the volume that should reduce before I will try my IVF? Would you give that tip to my audience?
To be as normal as possible is what we would like it to be, but obviously that is not going to be achieved.
So how many patients do you manage that with medical therapy?
Most of us with adenomyosis, we will manage with medical therapy unless she's got an adenomyoma.
Okay. So in this patient, you don't want to
global.
touch?
This is
I did. So we have sent her back to give 6 months of medical therapy and then try IVF. Because I think for this, if pain management is student, hysterectomy is the answer, whatever the age.
I think the patience of the patient and the doctor is very important in such cases.
Of course.
That's it.
Right. So this is what it is, and anyway, I think we just talked about the two approaches. Surgical challenges in doing an adenomyomectomy, Dr. Arnab and Dr. Manju. What are the surgical techniques you will use and what are the challenges?
So the technique that I use is basically I first dissect the most prominent part of the bulge, and then what I do is encore it. I just don't scoop it, I encore it. And I always put a sound or a dilator inside the cavity. Many a times I have entered the cavity also. I would not say many because these are surgeries which we don't do too many. In my lifetime probably I have done 6 or 7 such surgeries, not more than that. And I have been forced to do actually. I did not want to do.
I truly agree.
Because
I truly believe you.
This I have been forced to do. And here, once you do that, then what happens is you have got 2 flaps. Now, if you have got good flaps, it will come together, and with the barb sutures that we have, you will be able to suture it. Initially I used to do only wedge, and that is a very bad technique, because if you do wedge, you are losing a significant portion of the flap, you are losing a lot of myometrium, you cannot put it back together.
To Dr. Manjula, and then I want Dr. Krishna and Dr.
So finally, what we need to understand is that the decompression is the main thing. It's how much of the amount of the adenomyoma can be removed. So I think first the counseling is we can never remove 100% of it. So we have till near almost 80 to 90% of it is something which we have to remove. Then comes the technique. We do not have any capsule. We do not have any pseudo capsule. So it will be very difficult. So the lineation is good. But one good thing is I want it.
No? Take another.
So one good thing about it is that the amount of vasopressin when we give, when there is a resistance, that is adenomyosis, when there is very easily going, it is myoma. That is first thing we need to understand, because most of the time sonologists, younger sonologists, not Dr. Praveen, when they give fibroid, and when we go in, we see adenomyoma. So that's the thing. So once we give vasopressin, then we have so many techniques. One is like, I prefer either oblique or actually the 4-petal technique, or we have an inverted T or a T shape. Because when we take out as a flap, we need everything back. Like he said, we cannot end up losing out the serocell margin. So when we go, then we remove the end toto using, again, either my favorite instrument is harmonic, so I use harmonic. And we remove the whole of the globular mass which is there. If it is local, done. But if it is the global adenomyosis like this, if the pain is the main thing and pregnancy is not the main thing, we can still do a decompressive surgery of anterior and posterior adenomyomectomies, means as much as possible remove. Now, after that also is medical treatment.
I think adenomyosis deserves medical treatment. So let me just share with you one case that we did some time back. That was the anterior uterine wall, you can see. We measured it in our MRI exactly where we are. So this is the picture that we got when we entered, and she had such big vessels attached to the anterior abdominal wall. Anyway, we managed that, and then what we did is we had actually completely calculated the volume that we had to take out. Because calculation, an important decision of how much volume you want to take out in your adenomyoma is very, very important. And what we used is what is a small ureteric catheter. So we just put it in because we know each of these marking is 1 centimeter. As a malleable one. We just put it in, make the central incision, and then scooped out, as Dr. Arnav said, and then put this inside to check how much have I scooped out. So this is inside and this is outside, that is 3 centimeters on this side, 3 centimeters on that side, and that's how I know that I have got my whole adenomyoma altogether. So once we do that, and then we also calculated vertically how much we have resected, and this was the specimen that we actually removed. That was a huge adenomyoma that we removed. The volume from 700 cc reduced to about 146 post-surgery. She's still undergoing some fertility treatment and I don't have the information for her. So the last thing that I'm going to take you through algorithms. Now I want Dr. Partha to look at this.
I want to say something.
Oh, sir, please.
I want to say something. I just wanted to ask, what is the role of HIFU?
Role of HIFU, no sir. I
No,
don't
sir,
believe it.
absolutely no rule, sir.
No. We are not doing it. We don't
No,
have
that's
it.
what I wanted to know about.
Alright, so this is an algorithm which just simply was published. Would you like to change anything in this, or would you like to manage your patient with this simple algorithm, with endometriosis and pain, with all the things that we discussed today? Or do you think this is a good take-home message for the fellows and the junior doctors? Any point would you like to make it different? Anybody in the panel? I asked Dr. Partha, but anybody can chip in. Sounds good?
Yeah.
Everybody agrees?
I would just say symptomatic when in the future wishing to have children, LNG IUS, I would just put it.
Okay, I think that's a good suggestion. Anybody else wants to add? Any audience can add? No? Okay. So the same algorithm for patients who are suspected to have endometriosis but are looking for fertility. And where I would like to have opinion of Dr. Durga, which do you think if we proceed in this way, are we doing right? Or are we not doing good for the patient as long as the fertility is concerned?
Fair enough.
Fair enough?
Yeah.
You think that's good? Okay. So now,
Durga still did not answer.
Dr. Savita, do you think this is a good take-home message for our?
I think fair enough.
Sounds good, right? Great. So just one question to the audience now. This is audience poll. Scar endometriosis. How many of you will treat it with medicine and what?
Yeah, medicine won't work. Only surgical.
Hey, I didn't ask you. Audience, don't prompt them. Anybody would like to try medical therapy? Patient says, I don't want surgery, madam. Anybody? Hands up. Yeah. That's the take-home message. It doesn't work in scar endometriosis, and you can see these are the two scar endometriosis that we have done recently, and you can see this is there. What is the why is scar endometriosis?
Avoid scar endometriosis.
Ah,
it is
good.
because of all of us using our very carefully using the mops. We want to use only one mop for cesareans. So we use the same thing to clean the endometrium, and again on the top of it we stop. So once we put a mop inside the uterus to clean or remove the thing, please put it in dustbin immediately.
Don't use a mop only. Don't use a mop. In normal delivery, how many are you using mop to clean the uterus? Why do it in section?
They use a suction inside and then put it on the top. So it is the ectopic implantation rather than the metaplastic theory here.
Yeah. These patients don't have endometriosis. You do laparoscopy, they'll have abdomen will be clean. Yes. Okay, and that is correct while doing section. What would you say to this patient?
I have got this couple of questions.
Yeah. Look at the MRI. This is just 1 week back, one week, 10 days back. We have done. Look at the endometriosis in the perineal in the area.
Placenta when it is coming, we take
It's a de novo episode of scar.
Episode miscarriage. So this was again resected, and that was the endometriosis, the perineal endometriosis specimen. What is the last question? Sorry, I'm coming back again. Last question. What is the relevance of foam? Focal adenomyosis of outer myometrium. Dr. Krishna Kumar.
It's an extension of dilation, which comes from outside to inside, rather than endomyosis, where we believe it is endometriosis growing into the myometrium. Here it is the dilations, which are coming from external to the internal.
Yeah.
The whole theory about foam and foam or foam, how do you pronounce it?
Doesn't matter.
Whatever is different. Maybe it is endomyosis internal, endomyosis external.
Yes. So I think it is also important that when we are doing surgery for endometriosis, for pain or fertility, we must excise it as far as possible. And the posterior wall focal adenomyosis are now implicated in development of deep infiltrating endometriosis. So if you have that in the posterior wall of the uterus and the patient at the moment does not have DIE, better excise it because that will lead to DIE in that retrocervical area, and that should be excised, which is we had a spot here in this patient, we had multiple spots. That is in the anterior part of the uterus where we found the spot and we excised it completely. So that is something, and I think Anybody would like to add anything about diet and endometriosis? Would you advise, because patients ask.
I tell them to eat less KFC chicken.
Okay, great. Okay, what else? Dr. Arnav, last questions from everybody. Would you ask her to change anything?
Yes.
The most important thing is.
Okay, let Dr. Savita finish. Yeah, Dr. Savita.
More vegetables and fruits and omega-3 and omega-6 fatty acids, anti-inflammatory diet because it's an inflammatory disease.
Okay.
And less of caffeine and less of alcohol.
Perfect.
And
You have made life of the young kids very difficult now.
But KFC, why do you specifically say diogenes? Lot of EDCs are there in that particular.
Yeah.
And then also take off all the plastics from your microwave and from your fridge.
Dr. Krishna Kumari, what is your take on diet?
Yeah, diet, I think following the basic nutrition plans for everybody.
Yeah.
I think good diet, regular
I think,
exercise
yeah.
is what is needed.
Perfect. Lifestyle.
And diet, it's not only about endometriosis, it is the whole lifestyle, so many diseases.
Relaxation techniques also.
So we agree today that endometriosis is not just a disease for medicine, surgery and fertility, but it's an inflammatory disease which is a disease of the whole body. Right? So mind-body interventions, lifestyle modifications will definitely go along with it. Spend the time with the patients, try to tell them what all they do. Correct? Tell them in front of you to please delete Swiggy and Zomato. That's the first thing they can do because that is the biggest source of quick matter. Please. Pardon me, you can do it, but just a joke. So one famous last word from everybody of what you take or what you would give a take-home message to our audience today regarding the panel discussion or the cases that we saw in endometriosis. Let's start with Dr. Basu. Yes, one famous last word. Okay, Dr. Praveen, let's start with Dr.
I would like to ascertain that ultrasound is one of the best imaging modalities in evaluating endometriosis.
Yeah, please.
There is no second thought about it.
It is such a dynamic test. All we need is good sonologists with good knowledge to be able to pick up.
Youngsters keep up with the research and come out with more practical and more better options for treatment.
I had a bicornuate uterus with endometriosis. There was a time when I stopped a train with the pain. So I treat endometriosis very aggressively, but what I did for myself is I had Mirena for 3 times till I attained menopause. So I think aggressive management is one of the main things. No, the other one was little. That's what it was. So that is what I did. So I believe in aggressive management because quality of life, because I do not want any disease to come in the way of their dreams.
I think having a clinical suspicion. I think a clinical suspicion, diagnostic aids, and appropriate treatment. The biggest mistake I have found in patients who are coming to me is, like we have been discussing, post-operative management. There are people knowingly or unknowingly have entered into the abdomen, did the surgery and stopped it, like you said, maybe they completed the surgery at that point of time, but they haven't given post-op management. I think there's a look at it with a long perception.
And I think many times that happens if the surgery was not performed by a gynecologist or in the presence of gynecologist. Many times ovarian cyst is just performed anywhere. Even if they write it was endometriosis, they don't understand as a gynecologist what is the long-term implication of not medically treating them. We find so many of them come back with it. I think all of us must have experienced that. Dr. Partha.
Yeah, that's why my only word would be awareness from the very beginning level to even the senior level, as you told me. Not all, even at our ages, are so not very much aware about it. What is doing, and rather more senior, say 60s or 70s, just to raise the awareness from the very beginning and from the budding stage.
Even a physician can treat diabetes, but we still have diabetologists. In similar way, I think when we are talking about endometriosis, in this day and age, even though a gynecologist can treat endometriosis, I think endometriosis should not come as a specialty by itself because there's so much ramifications when we are talking about this disease, right from the physical to the emotional and psychological aspect that it has. That's one. And the second aspect I think is diagnosis is the most important. I think even when you see a young girl saying that she has dysmenorrhea, oh, it will get better in 2-3 years time.
Get married after
Exactly.
And that's the only maqsad of life.
So I think diagnosis is the most important, because once diagnosis happens, then I think the thought process is in the right direction. Are we talking about pain? Are we talking about fertility? Are we talking about perimenopause, menopause? The variations in terms of management is so diverse based on where they are in their life. And I think this is where the speciality, even though we are going into super specialization now, I think it's important. It's not, in the gamut of everybody as a gynecologist to treat all these parameters. So I think, we are moving in that direction, and awareness and diagnosis, I think these are the two most important factors. So,
Dr. Varna.
Yes, very difficult to be the last one.
No,
But yes, okay. So the thing is, everything having been said, I would say one thing is, when we are embarking on a surgery, let that be the only surgery for the patient. Let that be the complete surgery. Even if we are doing a radical surgery, pelvic clearance, or if we are doing a conservative surgery. And please understand that, as Dr. Durga rightly said, that this is a subspecialty. We have to accept it, and let us send it to a person who does it the best. Let's not be amateurish in saying that I can do it, do a half-hearted job, that we'll do tremendous disservice to the patient and to ourselves.
Thank you. So honored to have you as panelists today. Last word from me before we close it. One is, remember to have patience for the ear to these patients. When they come to you, they have been suffering for years. And there's a word for it called anamnesis. If you talk to them from the time of their menarche to the point they are in, you will learn so many things. Just give them time. Give a smile and say, I have all the time for you. They will immediately relax and tell you. That's the first thing. Even if you don't have time, tell them. Okay? The second, of course, first surgery should be more clear. You must take the patient along and help her reclaim her life and quality, so that she can now live with pain-free, want to do what she can, which she so well deserves. Thank you so much for this day today, and thank you all for joining physically with us. And I think we are also live on the Facebook and live on YouTube. I hope these messages have reached many more. Thank you so much today. Thank you. And I thank Mr. Rajesh from AstraZeneca for giving us this opportunity for sponsoring today. Mr. Rajesh is right here. Mr. Anand and Mr. Divakar is here from Apollo, helping us with all the audiovisual. Mr. Haridhar is there from Medical College. They were the ones instrumental in getting this live on YouTube and Facebook. Dr. Rani, we missed you in the beginning. I think you were busy in the OT. Please join us for one photograph, everybody. Please, I want all of you to come up.
I think one thanks on behalf of the panelists to you.
Thank you. I think we actually come on. Before we leave,
I request Dr. Vidya Rangarao to please hand over the mementos to the panelists and the moderator.
Thank you for coming. Thanks for coming all the way. Please stand. Just let us first give the I know. So I will request everybody to come on stage for a photograph. We ran out of it. All right.
I want all the girls to come up. Come, everybody come. I just
Sir, come this way.
I like the pattern. It should happen. Very good. Come, girls, come. There, everybody. Yeah, say cheese. Thank you. Who's Photos, of course, of course, so very glad you made it. I thought it was nice.